So once again, we're looking at anatomy with movements as the central part of our network of meaning or of our semantic network. In this case, we're looking at hip flexion. You can call it femoral flexion. You can call it different things, but generally speaking, people would use the term hip flexion. So our objectives, as is consistent, a specific discussion of what hip flexion is with respect to planes and axes, general discussion of the muscles that flex the hip, very general discussion of the neurovascular supply, and then a general discussion of the areas to assess and treat if hip flexion issues are suspected or reported. So I've got that typed up a little funny, please discard that, but that is what we're going to do. We're going to look at the areas to assess and treat should issues with hip flexion be suspected by the practitioner or reported by the patient. So our quick review of planes, flexion, the sagittal plane is a 50% cut of the body left to right. The horizontal or transverse plane is a 50% cut of the body top to bottom, and the frontal or coronal plane is a 50% cut of the body back to front. With respect to the sagittal plane, or with any plane, the axis is perpendicular to the plane. So the sagittal plane has a horizontal or transverse axis. The horizontal or transverse plane has a vertical axis, and the frontal plane or the coronal plane has an anterior to posterior or posterior to anterior axis. Flexion, in this case, with respect to the hip, happens in the sagittal plane. It is movement of the thigh towards the front of the body or towards the abdomen in the sagittal plane. So it's essentially so you'd have the thigh here. It's like it's moving towards the abdomen along that horizontal or transverse axis. So it's a rotation towards the front of the body along that horizontal or about that horizontal or transverse axis. With respect to the muscles for the hip, what we're looking at here for hip flexion is actually a lot more muscles than many people would immediately discuss. So the muscles that people would immediately discuss are primarily psoas major, sometimes psoas minor, iliacus, or the iliopsoas. The rectus femoris, some people would talk about sartorius pretty quickly, right? But we have to add in some muscles here that are going to be hip flexors or at least assistive. So we're looking at, just to go through the list from top to bottom, the psoas major, the iliacus, sartorius, gracilis, pectineus, the tensor fascia lati, or the TFL, although its primary function is to put tension on the iliotibial tract or the iliotibial band, it does assist with hip flexion. The gluteus minimus and medius, at least their anterior fibers, are known to contribute to hip flexion. The adductor longus and the adductor brevis also are known to contribute, at least in some degree, to hip flexion, which means we now have a much larger area to look at. So while you may, in your treatment or in your assessment, be able to omit the quadriceps group, generally speaking, you have to check the entire thigh. So the medial compartment of, or not the entire thigh, but the medial compartment of the thigh, the anterior compartment of the thigh, as well as the muscles around the trochanter, at least on the anterior half of the greater trochanter. You're going to have to check these if there are issues with hip flexion, on account of the fact that the muscles that will at least assist in hip flexion cover a much larger area. So now we have a larger area just on the muscles alone than one would think. One may think that you can just get really close to the greater trochanter itself and just kind of check around the top on the front side. But in this case, you may have a much larger area to check if these issues are reported or suspected, as we know. As far as the neurovascular bundle, because you have the glute minimus and glute medius, you end up actually having to think about the superior gluteal nerve and artery. So you're actually going to have to go around to the backside of the body to some degree, or the backside of the pelvic region, if you have reason to believe that there's a problem with those muscles. With respect to everything else, you're essentially looking at the distribution of the femoral nerve, the obturator nerve, and in the case of the psoas, you're going to have to look in the lumbar column, not only for the relationship to the direct branches or the anterior primary rami off of the lumbar region, the lumbar spinal nerves, in varying levels depending on the source that you check for the psoas to be for motor innervation. So there's sometimes you will see T12 to L3, I think. Sometimes you'll see L1 to L4 as far as direct muscular branches off the anterior primary rami of the spinal nerves at the varying levels to innervate the psoas. So you're going to have to check the lumbar column for the innervation. You're going to have to check the lumbar column as a proxy for the blood to the psoas, you're going to then have to consider the femoral nerve, the obturator nerve. So essentially you're looking at the lumbar column anyways, because those nerves come out of the lumbar plexus. You're going to have to look at the inguinal ligament, the anterior soft tissues of the thigh, and the medial soft tissues of the thigh with respect to those two nerves and their distribution. As well, you're thinking about the femoral artery and the obturator artery. So again, you're going to be checking the inguinal ligament, the anterior soft tissues, the lateral or the medial soft tissues rather of the thigh for the artery, the branches thereof, the I believe medial and lateral circumflex femoral arteries and varying other arteries that would branch off of the femoral artery are the things that you're looking at here. So what this does is it again gives us this idea that although we may be looking at the motion, if we look at the motion as our prime consideration, will be accurate to the situation at hand, as opposed to looking and tracing the neurovascular bundle as if that's going to give us our solution. It's going to be some portion of our solution. However, if we look at the movement problems and the differences in tissue tension in the regions that we would be considering, will be as accurate to the problem that's at present as we can, as opposed to chasing these neurovascular bundles, because the neurovascular bundle may be okay, but the movement may be having a problem for varying reasons. So sticking to the movement is the most appropriate thing to do as far as assessment and treatment is concerned, as opposed to chasing the neurovascular bundle, because you can see with just one motion, with just hip flexion, we're going to have to check the entire lumbar column. If we believe it's a nerve, we're going to have to check the tissues around the greater trochanter. We're going to have to check the anterior tissues of the thigh, the medial tissues of the thigh, the inguinal ligament. We've got a bunch to check. Now, we're going to do that anyways with respect to where we're assessing for hip flexion. But if you chase the neurovascular bundle, you're probably going to mess up what's right in front of you, which is the differences in motion with respect to the femur itself, as well as the differences in tissue tension in these areas. So if you look at those things, you're going to behave as accurately to the situation at hand as you can, as opposed to thinking that you're going to pick out a nerve fiber or an artery, because you're not going to do that particularly well, but you can get to the movement quite well. So as we've already noted, the issues or the areas of consideration for assessment and treatment, the lumbar column, as we already noted, the neurovascular bundle, the proximal psoas, the inguinal region for the neurovascular bundles, the anterior soft tissues of the thigh, the medial soft tissues of the thigh as well, although not noted there, the anterior region of the greater trochanter with respect to the TFL, anterior fibers of gluteus minimus and gluteus medius. You're going to have to check all of that. Wherever you find a movement problem or a problem with yield to pressure for soft tissues, that is where you treat, as opposed to just treating everything in the area. You treat based on what you find with respect to the movements that you're testing. As far as contraindications and red flags, known fractures or tears in any of these areas, refer out. Suspected fractures, known fractures or tears rather, do not treat, because you will make them worse. Suspected fractures or tears, send them out for further differential diagnosis to rule out the suspected fracture or tear. If there is no suspected fracture or tear, treatment is relatively fair game. If there is a fracture or tear, you don't treat in that region because you can make it worse. With respect to the lumbar column, what I would add in is any rebound tenderness. So if you push on the abdomen for any reason and let go, if you push down and it doesn't hurt, and then you let go and it does hurt, that is a visceral pathology until proven otherwise. So if there's any reason to check the abdomen and that occurs, you refer that out immediately. That is an absolute red flag for treatment. So those are the things and the areas that you're going to be considering with respect to issues with hip flexion.